There we go. All right, we're going to stay here. Thank you very much for still being here in the afternoon. Myself, Florian, and Clay are going to spend a little bit of time with you guys this afternoon. Maybe it doesn't move. Well, I feel technologically irrelevant right now. How do we move? Nope, nothing's moving. There we go. Yeah. So Florian, I'm the guy on the left. Clay's the guy on the right. We're going to keep on going so that we don't stall you guys much longer. So we are representing SciOx. We are a health information exchange and health information management company out of Alpharetta, Georgia. What we do is be kind of in the middle of serving the ecosystem, the health ecosystem, for a series of different kind of sources that you can see on the left-hand side, all the way on the right, that way, a series of different kind of purposes. So the kind of information that we typically retrieve and manage on behalf of a lot of the hospitals would be the medical records, images. We go into clinics and practices to try and retrieve those medical records, all the labs, information, so on and so forth. We go after all of that, package it, push it through our platform to help formalize all of that aspect, and then deliver it for a very wide series of use cases. Either you want to do risk adjustment, you want to do quality assurance, you want to do continuity of care, you also serve legal purposes. There's a wide array of reasons as to why people come actually to us and ask for medical records. When you try and put it into perspective, and that's a little bit of the conversation we've seen throughout the 2 days, yesterday and today. There's a lot of hospitals, a lot of clinics, a lot of endpoints that start making themselves available in a very digital format. Our reality is that maybe about 60 to 70% of all we deal with are faxes, pages of papers. We have mailrooms throughout the US where every single morning we've got UPS, USPS, and DHL dump a ton of paper that we need to scan, that we need to understand, that we need to digitize, and that represent medical records for about 80 million patients every year. So we have about a 1 million customer every year that request information that eventually we dispatch those requests through a network of health information management departments that we manage. So we are managing about 3,000 to 4,000 departments across the US. That represents about 60% of all hospitals in the US. And as much as possible, we try and go digital, right? So whenever we receive a request for a medical record, we try as fast as possible to go straight into the EMR if we can. So Athena Health and others, perfect. If it's not directly a SaaS solution, then we try and go with a direct connect kind of solution or a FHIR-enabled kind of environment, and that's another sweet exchange and the ability to retrieve the medical records. Unfortunately, a large amount of time for us, we end up having to have someone manually go into a medical record, save the medical record into some format of a PDF or another file, and send it back to us, and we have to kind of re-engineer the document so that we can make that record once more a digital document upon which we can do some analysis, do some version of transformation, and then eventually extract executable information, health information, so that we can do anything that's needed between continuity of care all the way to clinical trials, which is some of the things that we support. For the endpoint delivery, oftentimes, quite a few of our clients start getting very mature and also want to have a FHIR connectivity and be able to directly connect with us through those kind of APIs and be able to get that information digitally right from the get-go. Many others still look at an extract of information in more of an OMOP or any kind of other standard. And then Excel is still a very prominent way to exchange information, and we still have PDF and other very kind of closed proprietary structures that we need to deliver. So taking you a little bit into our world and what we get to live with every single day, this is our platform. We'll get into a little bit more of the details, but that's the platform that supports all of our business. It helps us take all of those requests that you see all the way over there on the left-hand side, interpret them. Believe it or not, even though we have APIs opened and made available to our clients, a lot of those requests come into paper format and structure that we need to transform, and then eventually allow us to go after the right sites, the right providers, the right clinics, and ask for the medical records. To help us along the line, and we'll get a little bit more into the details of this, we curate a database of about 45 million patients with variability on names, first name, last name variability, depending on the site where they've been. Same idea on the hospitals, an hospital that was acquired and changed name over time. We need to kind of figure out what that is. Same for the providers, their credentials, the change of name, so on and so forth. So all of that is what we kind of put as an intelligence to help us be digital first, or as digital as possible in the manipulation and delivery of medical records. So I'm going to share it with Clay, speaking a bit more about the platform itself.
Thank you, Florian. So as Florian mentioned, he's described some of the problems that we encounter, but also the successes that we've had. But what FHIR means to us is an opportunity to actually build on some of the things that we've been doing for a number of years and decades in terms of being, a requester for information, delivering that to different modalities. But the reality is there are multiple different areas that something like FHIR actually integrates into our product stack, and probably represents something similar to the types of decisions you all have to make in terms of your enterprise architecture. And there's differences related to whether or not you're building an application from scratch, or whether you've been around for a while and you have a platform that has lots of data, has models that exist that you need to keep into production and then bring in new approaches of data. And so I've tried to outline here 4 of those areas for us where HL7 and FHIR actually impact our day-to-day business. And I'd like to walk through a little bit of that experience in terms of where we've started, some decisions that we're making going forward that you all might need to do as well. And then ultimately, I'll give you a use case through some of this complex world and some of the messy world that Florian mentioned in terms of how we leverage FHIR, and also how we have to deal with some of the uncertainty of the data that we have. So I'd like to start from the right-hand side. I know that's a little unnatural. We all read left to right, but on the side with requesters, this is the first category that we've dealt with for a long time. That's how people make requests for data. And sometimes it's a system, sometimes it's an individual that may be picking up the phone, calling for something, or we all know that attorneys, which you mentioned before, are part of our court-ordered request. We may have to actually go get that information on behalf of them, and they don't have a lot of applications that the industry's focused on for attorneys, or some of those edge use cases yet, which are opportunities for us all. But in those cases, we may get faxes, we may get phone calls, we may get some of those things. Where we see the really great opportunity with FHIR already, and where we've seen an HL7 V2 and where we've seen with IHE in the past, is on the provider and the patient workflows. So we've done a lot of great things around that, and we'll continue to do it. But there's a messy world to the right, and it's a very, very wide net of requesters that we have to deal with. We don't get to stay within just the clinical and patient realm. So I was very happy to see some of the work on the Death on FHIR, where we're seeing these new types of workflows reach out to edge cases that maybe we don't think about very often. We stay so centered on the hospital and within the practice. So that's the first piece, which is requesters. On the far left, that's the more obvious piece, which is actually getting the data, which is, thank God for FHIR and HL7 and other things, that's a little bit more robust. We do still have to deal with things like HIM departments and images when full medical records may exceed the capability of a CCDA, for example, or that of an EHR. But largely that world is getting better and better every day, and we're encouraging ourselves to follow the communities and the opportunities, as well as the networks such as Commonwealth and Care Quality and things that are out there that can further that reach for us. And then the 2 last pieces, so that I can get to some of the workflow that I'd like to describe, is the piece below that, which is dealing with that unstructured data where you're trying to get that to a semi-structured form. And we've made significant investments in terms of OCR and NLP capabilities to be able to take data and text and move that into a semi-structured format. And there are great opportunities to do that on both the request side as well as the clinical content side. So we've spent a lot of investment and opportunity there, lots of hard engineering work for the folks back in Alpharetta, New York, and elsewhere that have done that. And then lastly, I mentioned the decision point that you may need to make as well is in your database and your canonical model. Are you going to leverage resources if you're a new application right out of the gate? There's some opportunity, and I saw some great work that I was very impressed by this week where folks have actually taken either toolkits or have taken approaches to build from scratch, database models that actually more resemble FHIR and resources or some generic form of that in terms of JSON or others and the relationships amongst it. So that's a decision we have to make, you have to make. So just pointed out that for new applications, a little bit different than perhaps applications that have been around and have dealt with data for a while. You'll need to consider how you integrate those. So, and then the last piece at the top, and then I'll move on to the workflow, is related to how new applications are going to interact with you. And clearly we see that is a FHIR capability. We do not want to reinvent that wheel, so that's how we will actually leverage new third-party products interacting. So very quickly, I'll move through this. We break things down into very four categories or queues, if you will. So a majority of our work, both people and process and software, work through an intake process. Then there's the acquisition piece, which is the digitization, locating those things, retrieving them. And then there's the processing. And based on who the requester is, there's many levels of processing that we do that include many things like coding, different things that we may do around quality for HEDIS or supplemental data that needs to be added to it that's not available in an electronic feed. But then lastly, based on site preference, we have capabilities to map a site to their preferred delivery mechanism, which we hope over time continues to evolve to be more FHIR-based. Today, that's several different modalities that we use. But the use case that I'm going to walk you through very quickly is within the digital grid world where we connect all this data and have the queues and how we process all of these things. There are two functions that I want to show. The first one is how someone actually goes about seeing the work request that comes in. And the case that I'm going to do here is actually through an attorney workflow. So where there's a request of information that has been authorized by a court system to be released. And so there's a dashboard here, and then behind the dashboard, essentially, there is a set of the queued requests for us going in and actually trying to enter these things into a fulfillment process to get the record. So this is one of those messy world items on the left-hand side that we deal with. So in majority of cases today, an attorney may fax a letter, and if you look at this letter, it's been scanned in through the fax, through automation. And then on the right-hand side is the digitization of the information that we need to be able to fulfill the record. And so in that, there are several key pieces of information that we use technologies like OCR and NLP to do as much work as possible for us because of the volumes that we deal with. We can't have people doing these things. The first is at the very top, and you'll see it says site location. So within the request letter on the left, you may notice that there's some information that represents where we want to get the data from, and this is how it comes to us. So there is some selection process to select the actual site that we need to retrieve information with, which is very complicated. It looks very simple here, but physical facility addresses are different than where a PO box is or where a billing department is for an organization. There's a lot of product within our company, specifically called Aggregation IQ, that actually goes through and tries to help make those decisions where possible. Most of the time, it does make that decision. Where it doesn't, then obviously, then we have someone that can interact and override what that is. The second piece is the request for information. And so in the request for information, that's pretty straightforward. That's who's asking for it. That information gets populated. And then the last information, which is really pertinent to the FHIR conversation, is related to the patient. So within this, the patient information has been brought over into this digital form. And then there's the type of record that's been requested. So this is from intake process. So the next piece, which is where we interacted with FHIR in this particular setting, is we'd been doing a lot of IHE profiles in XCA and XCPD in the past, but now we've extended that so that site preference can have one or the other. And in this use case, what you're looking at is we actually use the patient and the binary resources to a public FHIR server to be able to go out and pull down a CCDA document. And so you're seeing the first part of that. We can expand those things out. You know what those things look like, so I won't spend a ton of time in them, but that data is brought back within the system. And then ultimately now, without anyone doing anything, just using the site preferences and obtaining that data, we've gone out and gotten the record. And We put that into what we call fulfillment transmission. And at this point, the back-end system, which I don't have a screenshot for, which is actually extremely a very good but very complicated system, figures out the preferred method of delivery for a particular requester. And so that's the pieces that I want to work through. When we talk about what's ahead of us, so we started at the edge about getting more data because that's where we need to continue to get more efficient in terms, just like you all, about accessing data. But where we're going next is actually standardizing our current existing canonical model to FHIR and CCDA, obviously. But then as we move past those things, then we are currently into a lot of different product areas right now where we're in some pilots around big data analytics, specifically around aggregating data across multiple standards such as FHIR resources, CCDA, HL7, and obviously unstructured data. So,
thank you.